Good afternoon. It is a huge pleasure for me to be here. It was somewhat difficult, but here I am, right on time. So it is, like I said, a great pleasure for me to be here. Thanks to the organizers. Thank you, George. And I will talk to you about update on HPTN 083. That was the latest update. In 084, we have data that were presented recently at the Brisbane, Australia conference. And very quickly to remind us all, this is the study is exactly the same, but we just had the different populations. A study was on 43 sites throughout the world, and for MSN, men who make sex with men and transgender women, and the 084 in African countries for cisgender women young. So this is the actual design of this study. There was a phase with the use of oral tablet for 5 weeks so that we could actually assess the safety of injecting the individual. This oral phase was dropped when the drug was approved by the FDA. It was optional because there was nothing regarding safety that would make this phase be capped. And then patients were randomized to get either active cabotegravir, TDF and FTC, placebo, or vice versa. So everyone had an active drug. And for those who wanted to discontinue or who got to the end of the follow-up, we proposed 1 year of tenofovir and tritabine to cover the tail that the drug leaves because it's a long action. The study 077 for low-risk individuals in which showed that this drug persists in the body for a long time, about 78 weeks, but at levels that keep decreasing and decreasing. So our worst fear is that due to this tail of drug, because it's a long-action drug, we were afraid that any infection during this tailing phase, because the person wouldn't be taking the tablets, would lead to integrase resistance, and that's it. I mean, these are the data, efficacy data in the 2 first years of the study. We have a 66% decrease in HIV infections at the HPTN 083. In HPTN 084, there's superiority of cabotegravir. Cabotegravir, therefore, was superior to tenofovir and precitabine in study 083 for men who make sex with men and transgender women, and in the 084 for cisgender women, the superiority of cabotegravir was of 89%. It is therefore a drug highly effective for every population where it was studied in clinical trials. So here we can see this efficacy assessed in several subgroups, age-related, gender-related, etc. But what we saw was that it was effective in all groups listed on the table, including the distribution per region. There was no important difference. We are now publishing the specific results of the 083 cohort. Is the largest transgender women cohort ever included in a PrEP study. So it's a cohort of nearly 500 transgender and transvestite women cohort. Here we also have in age PTN084, and we see it the same way that results were absolutely consistent throughout all subgroups assessed. We also have here a summary showing that cabotegravir is highly effective at preventing HIV in young individuals black individuals, transgender women, individuals from various regions of the world, women under contraceptive methods, although we had several pregnancies in this study with no sign of, or no reason to prevent using the drug in maiden age women. At a certain time at this study, it was even possible to keep women who got pregnant under dolutegravir. They could be kept, of course, under uh, surveillance, but they remained with that. And also for individuals with higher BMIs. Regarding safety, the most important adverse event we had were reactions to injections. It was nearly universal, although most of the reactions were mild to moderate, and only 2% of cases in 083 it led to discontinuation of the regimen. So, on 084, you can see the huge resistance in young cisgender women. Only 21% had any adverse reaction to the injection on the standpoint of pain or any inflammatory symptom. Only 4% had grades 2 or higher reactions, and there was no discontinuation whatsoever in this study due to injection reactions. Therefore, our conclusions to date is that long-acting cabotegravir was safe and highly effective, well tolerated. The most common adverse effect was injection site reaction, most of those mild to moderate. And one important thing is that in time during this study, we clearly see that this injection site reaction improves with the time. Either the person got used or it's just like this, it's worse in the beginning and then it gets more mild in time. But we're still preparing the data of 084 regarding reproduction health. But as I said, we've already been authorizing this open label phase of this study because after the results were published showing this high effectiveness and superiority, all were offered to migrate to cabotegravir arm, and we had a mass migration to it, and therefore we could offer any pregnant woman would remain using cabotegravir. So now for the CROI, we will probably have the description of pregnancies. That will be a very important data. Keep tuned. Regarding failures, we have some important details to discuss. What are the issues? Cabotegravir, because it is a long-acting drug, it suppresses a lot of viral replication and delays the appearance of antibodies because it is a drug remaining for a long time. Rapid tests and also antigen antibody fourth generation assays usually fail to detect infection. So other tests also based on antibody may fail and or they may remain indeterminate for several months. And in addition, viral load is kept low, very low, or undetectable due to the high effectiveness of the drug. So we have a huge challenge, which is to detect infections under the cabotegravir for PrEP. What leads to non-detection? Well, late start on antiretrovirals and possibly new injections are administered because this is not an easy diagnosis, and the appearance of integrase mutations which appeared in some cases. We will see further details. In HPTN083 we had a rare infections, the so-called breakthrough infractions, when the individuals were using the drug properly or in other circumstances. They very rare, but there is no explanation so far. Now we have a total of 7 cases. Here it says say 6, but it's 7. And mutations to integrase resistance appeared in 100% of the 7 cases. At the same time, on HPT084, we had very few infections and no breakthroughs such as those we just saw for 083 due to the proper use of cabotegravir, and no case of HIV infection on 084. No, I mean no mutations for integrase. Here we see further details, these cases. I will very briefly mention cases A, where HIV infection was not detected before injection, although in screening, those individuals had a viral load up to 14 days before beginning in this study. It shows that their entry was based on an antigen antibody test and it was detected afterwards. So out of the 4 prevalent cases, in one, we had the appearance of resisted to integrase. And then we have group C. So I will come back to BR later on. The group C is that of individuals who were infected during the oral phase, which is now optional. Fortunately, because there is also this risk. Who will benefit the long-acting PrEP? Those individuals with a difficult adherence. So we impose those 5 weeks of oral drug, and unfortunately we had 3 infections. Out of the 3, 2 had the emergence of the mutations to INSTI. So we have this case BR1, which in fact these were 2 cases. One had the emergence of mutation to INSTI. And what are those BR1 cases? We have cases B. These cases B are the cases where the person disappeared or dropped out, and the latest injection was over 6 months ago. So that fear I told you about before of the tailing of the drug, perhaps that was our worst fear, seeing resistance mutations when the tail would be fading. We had none, and that's quite interesting. This is group B. We also had group BR1. The BR1 group were people like those I told you about, people who were not getting injections for over 6 months, but they came back. As they came back after 6 months, they were injected, and we realized that those had an undetected acute infection. It's a very similar case to those 4 cases I showed you before. And out of these 2 BR1 cases, one had the emergence of INSTI mutation. And then we have a group D. That is our greatest concern regarding cabotegravir. We have 6 infections in group D where people adhered completely to the treatment and took the injections on the right date. So we still don't have a final explanation. We are performing a control case study to check, to try to find an explanation to this. And the explanation we started to realize is that these are 6 plus another individual who delayed 10 weeks, 8 weeks would be the deadline for the new injection, and he was 2 weeks late. He got the injection with this 2-week delay, and he was also infected. And that is a situation where we didn't see any mutation to INSTI either. So, in fact, in situations like these where there is already a decline of the cabotegravir levels for the delay, we don't see mutation emergence. We saw mutation emergencies when there were high levels of drug remaining. So what happens? We found out that in the 6 first cases, some had a faster clearance of the drug, meaning that the drug was reduced faster than the pharmacokinetic pattern, and also compared to other cases. It happened uh, for one of these individuals and in some points to other individuals among the 6. It is still a situation being studied. We still don't have a final explanation. This is not necessarily the explanation, and for this we need a control case to check whether or not those who didn't infect, what was the drug pharmacokinetics, and this is still in progress. So we have here data presented at CROI this year, talking to what we baptize the Levi syndrome. The Levi syndrome is an anti-syndrome because a syndrome includes signs and symptoms. Here there's no sign, no symptoms whatsoever. And here on this slide we show the differences between an individual with the Levi syndrome and individuals with a classical acute infection picture, because the Levi syndrome is only an individual with a seroconversion and acute infection during the action of this long-acting drug. And this individual, in cases we saw so far, which were very few, there were no signs or symptoms of acute infection. And these are infections that behave differently, particularly regarding the viral load figures, which are very low, and they may float to detectable. So it is a situation of difficult diagnosis, and that is the greatest challenge to the implementation of cabotegravir. So 7 out of the 16 infections, like I told you, develop mutation to INSTI. We still don't know whether or not using dolutegravir or first-line treatment for infecting individuals will be an option. Because in this study we did not use dolutegravir. It would be a 5 urines for those without access to darunavir, or a darunavir-based regimen for those who had access to it. I just came back visiting several implementation studies. One has just started in Africa. We are going to have our implementation study in 6 different centers coordinated by Fiocruz, and all implementation studies will use dolutegravir-based regimens in first line. So we're going to monitor those individuals up close to detect the failure early on, and then shift to a different regimen, because the availability of the darunavir around the world is quite limited. And here in Brazil, we can actually monitor this individual up close and shift to a darunavir-based regimen in case of failure. So this is just a summary of everything I told you so far. I still have a few slides to show you, so I will run a little bit faster. So despite all this, on this slide, for instance, we had the results of a mathematical modeling performed by Professor Randall Phillips of London. And it shows that despite, he clearly saw in the modeling that there will be an increased resistance to dolutegravir, but despite of it, there will be a 27% decrease in HIV incidence, and this was done for the African setting. There should be a 27% decrease in HIV incidence in that particular setting if the drug is implemented in PrEP. And in addition to those 27% decrease in HIV infection, of course, a lower detection of cases. And despite this resistance emergence, in the end, we will certainly see a decrease in HIV-driven mortality, and this is the most important outcome we want. The end point. This decrease will be consistent even in face of those issues related to dolutegravir and its implementation. So we just had in Brisbane, now I am shifting gears to 084. These are positive predictive value of HIV serological assays. And very quickly, we saw that a quick test alone has a very low positive predictive value. So there must be a combination of fast tests in implementation because one test is not enough. The two positive fast tests is okay, and then we can kind of assess the positive predictive value using two fast tests to start the screening. So we have the situation of false positives, which would lead to serious consequences, because if you base yourself on a positivity test when there is no positivity at all, you are going to give someone an HIV positive diagnosis. You will start the individual on antiretroviral, and given the difficulties of diagnosis after you start with antiretrovirals, this is a situation that we must try to avoid. On the other hand, we have negative HIV tests, as we saw before, such as 083, which may also lead to a late detection and late prescription of antiretroviral and the resistance emergence. So there must be a balance for a cautious assessment of such situations. In 083, we are going to present it next CROI results regarding positive predictive value, and this data are still under analysis. What I am showing is data for 084 for women. So, one thing I would like to tell you is that in both studies, because now people are in the open phase, everyone who wanted is getting cabotegravir, we have established a viral load for every visit. So, right, the times of open studies we are experiencing will certainly give us important answers regarding the utility of viral load methodology in the follow-up of these individuals under cabotegravir for prevention. Another study that was presented, and with this I will end my participation, these are initial results of HPTN084 on choices. Like I said, after results on efficacy and safety were released, it's a highly effective drug. What happens? We offered cabotegravir to everybody, and whoever wanted to start it on cabotegravir. But there was a whole talk about choosing, how to give advice to the individual so that the individual, it's him or herself, would make the decision either to be kept on oral PrEP or migrate to oral cabotegravir PrEP, or if she wants to go to cabotegravir. And what we saw that a majority decided to go for cabotegravir, and we also applied a scale that shows what was the decision based on. This is important for us to understand how the decision-making process took place. Like I told you, a majority, 78%, decided for cabotegravir, and the reasons for it were especially related with preferring injections or because they just don't like swallowing pills. On the other hand, those who went for tenofovir were those who would rather take pills than injections. And it didn't vary with regards to the groups. And in a very interesting way, this was a decision based on the desire of the individual, and the guidance of the advisor or the doctor regarding options did not influence the decision-making process. This is interesting. It shows that we must educate the individuals we care for so that they themselves can take well-informed decisions based on their own desire. Like I told you before, most of 084 participants chose cabotegravir for PrEP, and the choice was essentially based on personal preference and the attributes of products, and patients or participants also didn't express much conflict in their decision-making process. Of course, Those individuals were in the study for at least 2 years, so they had already had an experience both swallowing pills as well as taking injections. And that was it I wanted to show you today. I hope it was useful. Thank you.